This is Brian Warmers recording a lecture for medical surgical nursing on preoperative nursing. These are your learning objectives that I can let you work through on your own. So preoperative period, so this is any time from when the surgery gets scheduled to the time that they actually enter into the surgical suite. At this time, the nurse really functions as an educator and advocate, a promoter of health and of safety. And some of the reasons we do surgery would be diagnostic, so we're trying to figure out what's causing some of these things. It can be curative, to remove or repair whatever's causing discomfort or disorder. It can be restorative, to improve functionality. We can also look at palliative, so it's not going to fix the problem, but it might relieve some of the symptoms. And then we can do it for cosmetic, so such as tummy tucks and rhinoplasty. So urgency and degree of risk of surgery. So urgency, how fast we have to use. Elective means that it's not an acute problem. We can do this as a scheduled procedure. Urgent means it needs to be done, but it's not acutely life-threatening right now. It could be if it doesn't go on or if it gets untreated, but it's not emergent. And emergent means, of course, that it's an immediate intervention because the patient will die. Degree of risk, so minor surgery, a little risk involved. Usually it's kind of a local procedure, otherwise it can be major, such as a big extensive surgery. The extent of surgery can be a simple one, just to a very specific area, otherwise it can be very radical, involving the area that you're doing surgery on as well as cutting around that. We also are liking to do more minimally invasive procedures lately, and so we're taking scopes and using those scopes to make minor cuts and minor incisions into that space, and that promotes wound healing. So some collaborative management for our assessment of this would be, history and data collection. So looking at it for any problems. Age does make a difference in surgery. The very young and the very elderly have decreased immune responses and typically will do worse in surgery. What kind of drugs and substances are they on? This can affect their response to anesthesia if they've been on multiple narcotics in the past, if they've been on anything that might affect their respiratory drive. We can also look at their medical history, including cardiac and pulmonary issues. We want to make sure that they don't have any major hemodynamic changes during surgery. Things that would affect this would be, do they have a history of COPD or breathing problems or heart failure? All that we need to be very careful with. And then we can consider prophylactic antibiotics to try and prevent them from getting sick during surgery. We want to know about their current medications and talk to the providers about which ones they want to continue. Generally speaking, anti-seizure medications are a good one to continue because we don't want them to have a seizure during surgery, as well as a lot of your COPD breathing ones and your cardiac ones as well. Also want to know about previous surgical procedures and anesthesia and how that went for them. If they've ever had something called malignant hyperthermia, that is a bad thing. We need to note that and pass that on, and we will cover that in the next presentation. Have they had any blood donations before? Have they had an autologous blood transfusion? And that is them getting their own blood, and this can be done up to 5 weeks before surgery, which is a nice thing to know. Otherwise, is there any directed blood from another family member? Otherwise, we just got to do a type and cross and make sure that the blood that they're getting is not going to react with them. Discharge planning starts from day one, and what's their ability to go home and do self-care? Some of the things that we look for prior to surgery will be obtaining some baseline vital signs. And this is crucial, especially when you're talking to those post-op nurses, because they don't have a baseline for this patient. All they have to go on is your charting. We need to focus on some of those problem areas, looking at all the body systems and how that's going to be affected by the procedure. And then we have to report any of those abnormal assessments to the surgeon or the anesthesiologist. Assessment. Some of the things that we can do with this, we'll be looking at the cardiovascular system, looking for any heart attacks, MIs prior to surgery. We're looking at the respiratory system for any problems with respiratory, so COPD is a major one, sleep apnea, anything that can affect that oxygen delivery. And then, of course, we're looking at kidney impairment related to how that's going to metabolize the drugs and can they get it out of their system. Neurological, we're trying to determine a baseline. And like I said, that's really important for the post-op nurses because all they go on is your charting. We also want to assess level of consciousness and ability to follow commands and musculoskeletal, any gross deformities or anatomy issues that we have to be aware of in or out. Nutritional status. Um, those people that are malnutrition or obese have increased risk of surgery for not wanting to heal after surgery. And then, of course, psychosocial. Everybody's a little nervous walking into a surgery. What can we do to help them out? What's their coping ability? Laboratory assessment. So some of the big things that we look for: UA. If it's going to be a bloody surgery, we might do a blood type and cross match. We'll look at TBC to get a baseline. We'll look at clotting studies to make sure that they will start clotting after surgery. We'll look at electrolyte levels to make sure that they're not going to have any seizures or other um, arrhythmias during surgery. We might look at kidney function with the serum creatinine level. A pregnancy test for all women is very important if they're of childbearing age. It's amazing how many people know they can never be pregnant, but you do a pregnancy test and lo and behold that they are. So make sure that you do that on all women of childbearing age. Might do a chest x-ray to look for any pneumonias, and we might do an EKG to look for any heart involvement. We do make them sign an informed consent. This is something that the person that's doing the procedure needs to have the patient sign. This needs to be done prior to any sedation or any meds that would alter their level of consciousness. The nurse is there not to inform the patient, but it's just to make sure and verify the patient is doing this of their own free will. We are going to answer some of the simple things about surgery, but if they have very specific things, the person doing the procedure must clarify that with them. Patients may sign with an X. It's a little old-fashioned, but if they don't have a good signature, they can sign with an X. In an emergency, we'll still try to get one authorization if possible, but if it's true emergency, we'll just do it um, based on what's right and prudent. So dietary restrictions, this is a little controversial. Generally speaking, it's 6 to 8 hours prior to surgery. For most adults, basically, they say that this will be, from midnight the night before. What we're trying to do is decrease risk for aspiration with this. If they have an empty stomach, then hopefully they don't have that food go from the stomach up and over and into their lungs. So this should be a written direction because all too often it's difficult to understand for some patients. And then if these rules are not followed, if these instructions are not followed, then the surgery can be canceled. And that's kind of a common finding, unfortunately. As far as giving regular scheduled meds, we talked about this briefly before, but anything that's worked for cardiac disease, respiratory disease, seizures, or hypertension, these are things that we probably want to continue on, but run it by the anesthesiologist as well as the surgeon. Prior to surgery, we can do some anxiety interventions. Oftentimes, just giving the facts about the procedure will help them out, and being open and letting them to express their feelings can help. Promoting a good night rest before, while difficult, is a good idea. Use distraction techniques such as music, TV, reading, or visiting with family or friends. And then also teaching with family members can also help with um, support of this patient. So prior to surgery, we want to remove most clothing. We usually put them into a gown. Leave all valuables at home because we don't want to be responsible for this. We tape rings in place so they cannot be removed. But we really say that all things should be removed just because we don't want to be liable for losing them. And some metal objects can cause burns based on the electric cautery. We want to make sure the patient is wearing an ID band. This is of utmost concern because back once they get sedated, then they can't say what the name and date of birth is. And same for post-op. We do want to remove any dentures so they don't fall out during the procedure. Any prosthetic devices we'll take off. Any hearing aids, we'll take those out. Any contact lenses, we take those out. Fingernail polish will be removed. We can get better SATs. Any artificial nails, same thing, we remove so you can get SATs. And all jewelry take off. Prior to the surgery, we do like them to sign that surgical site just so we don't make an error. We want to make sure that we're doing the correct surgery on this correct patient in the correct place. So I talk about some of the piercings and stuff like that, take those out. Nowadays, it's amazing who's got piercings in what areas. If you tell them that this might cause burns to these areas, they might be more compliant with this. But just be aware that some patients won't always tell you about all the different piercings that they have. Skin prep. So what we're doing prior to surgery is prepping that skin. Oftentimes we're using antiseptic solutions anymore, such as a Hibiclens or a chlorhexidine prep. We're really trying to keep that skin intact though. We used to shave years ago, but what we're finding out is that caused infection related to nicks in the skin. And so now we might use a clipper if it's in an area that's got lots of hair. Just a map of some of the different ways to prep depending on where you're having your surgery at. Some meds prior to surgery. We can give meds prior to surgery, and that often decreases the meds that we have to give throughout the hospital stay. So if we give Ativan, or if we give pain meds, or if we give anti-vomiting meds, such as Zofran, prior to surgery, generally speaking, throughout the whole stay, we have to give less. It's better that way than trying to play catch up. We can also give something like an atropine to try and prevent laryngospasm and bradycardia from vagoming. We can also decrease gastric secretions by giving an H2 blocker such as Zantac. We can also decrease the amount of anesthetic needed for induction maintenance. Like I said before, by giving opioids. Intestinal preps, if we're working on the GI tract, we might have to do a cleanse or clean out. So this might include like a go lightly or a mag citrate. And the reason why we do that is trying to be able to assist for visualization. And then if we have a neck, then we don't have as much bacteria that would actually flow through that area. We also want to try and prevent complications. So this is teaching them how to use spirometry, coughing, and splinting. Generally speaking, this goes better before we give them any meds that cause alterations in mentation, such as anti-anxiolytics or opioids. But that's why we teach them early. Be aware that we're also trying to prevent DVTs and thrombus events. So by doing things such as anti-embolism stocking, maybe some medications that we're putting them on, such as Lunox. We're also going to be doing leg exercises and trying to get them up as soon as possible after surgery. We talked about VTEs. These are risk factors. So obese patients, patients 40 and older, history of cardiac or decreased cardiac output, history of cancer, decreased mobility, patients that have got a history of VTE or PE, patients that are on oral contraceptives, patients that have smoking histories, or patients that have had a hip fracture. Some things we can do, we put them on those compression devices, and hopefully you guys have seen those. Chart review prior to, we want to make sure all things are in line, all orders are complete, all labs are done, all imaging is set up and completed prior to procedure. We want to document good vital signs, allergies, height, weight, and make sure everything is ready to go. So national patient safety goals and informed consent. So we're really trying to make sure that the correct surgery is done on the correct patient on the correct site. And that's why we're doing the informed consent, as well as why we do a timeout prior to procedure. And the timeout is saying this is this patient, we're going to be doing this procedure by me or whoever the provider is, and just making sure that everybody's on the same page. Concerns with older adult patients. So changes that are associated with this, so cardiac output and peripheral circulation might be decreased, as well as vital capacity of oxygenated blood. We can also worry about blood flow to the kidneys. We do have increased blood pressure oftentimes, and then we're risk for skin damage if their skin is lacking the adipose tissue. And then we can have some sensory deficits. If they can't hear us, if they can't talk to us, if they can't see us, those can be issues as well. And then they might have special deformities related to osteoarthritis or osteoporosis, and so they need to be positioned in special ways. So, other considerations would be any allergies, any chronic illnesses, any malnutrition, any self-care abilities that might be impaired for afterwards that we have to be worried about. What's the stress from surgery or anesthesia going to do to this patient, especially if they get any comorbidities with this? Any mental status changes that could occur before or after surgery, or if this puts them up for a high risk for falls after their surgery. This completes this presentation on